why people are still fearful to undergo surgeries when it comes to kids, and how much importance it has, early intervention has in terms of pediatric surgery cases.
Because children, they run behind each other and one child
Right.
bangs the door and the other child is just holding on
Oh
to the
yes,
edge.
very common.
And then the finger gets cut, and I get such cases. They bring the cut piece, sometimes they forget to bring the cut piece. We do the repair, we do the reconstruction, and we can restore the hand.
I'm sorry, to be very specific for our audience, we are really covering month by month when the intervention is really required. So please see your doctor. Don't delay the surgical procedures. It's very important.
So I asked her, like, why are you coming now? Why didn't your parents bring you earlier? She said, when my parents took me to a doctor, the doctor said, wait until 18 years of age. And that was such a bad advice. General public believes that children, they don't form scars. The truth is just the opposite. Children heal fast, but they form aggressive scars.
Welcome to a special collaborative episode between two meaningful platforms, Expert Medical Insights by Dr. Mohan Rangaswamy and Med Talks by Dr. Anita. Together, we are on a mission to break myths and bring out the lesser-known realities of plastic surgery, especially in its reconstructive form, because it's far more than just Botox and fillers. With nearly 4 decades of rich surgical experience, Dr. Mohan Rangaswamy shares his deep insights on how plastic surgery plays a vital and often unseen role across various medical specialties. In this unique series, we have taken an A to Z approach, exploring how plastic surgery intersects with different fields of medicine, from gynecology and cardiology to orthopedics and oncology. And today, we are reaching the final stretch, specialties from letter P to Z, covering areas like pediatrics, urology, vascular surgery, and much more. So whether you're a medical professional, a curious learner, or someone passionate about healthcare, this episode is packed with valuable insights. Don't forget to subscribe to both our YouTube channels, Expert Medical Insights by Dr. Mohan Rangaswamy and Med Talks by Dr. Anita. Like, share, and follow us to help spread awareness and bring expert knowledge to a wider community. Let's dive into this enlightening discussion. Welcome again, Dr. Mohan.
Thank you once again. It's always a pleasure to be here.
Exactly.
and delve deep into this inter-specialty collaboration, which we started 2 months back, I think.
Yes.
And today we're coming to the final episode of this.
It always
This
seems like
is-
never-ending discussion with you.
Well, we will have much more topics to continue further.
Yes,
Every
absolutely.
month we will bring new topics. Yeah,
Absolutely. So we are at our letter P,
that's right.
coming to plastic surgery.
That's right.
Plastic surgery with pediatric surgery, to be
Right.
specific. Sorry,
Right.
I think I said plastic surgery.
No, that's right. P is for plastic surgery, but today we are not discussing pure plastic surgery, but we are discussing interactions, as always,
Right.
as we discussed in episode 1 and 2.
Right.
So interactions with
Pediatric surgery. So
Let's
pediatric
start with
surgery,
pediatric surgery.
Dr. Mohan, how pediatric surgery differs from adult surgeries in terms of plastic surgery, and why people are still fearful to undergo surgeries when it comes to kids, and how much importance it has, early intervention has in terms of pediatric surgery
Sure.
cases.
Sure. So there are two aspects to this. Anybody can get injury, burn, or these sort of situations where plastic surgeon service is required. So
right.
if that happens to be a child, okay, the pediatrician might get involved. The pediatrician needs to know where to refer and what are the possibilities and what are the value and merits of referring early to a plastic surgeon for wounds, for scars, for burns, and such situations. I also spend quite a bit of time educating parents, even if like the parent comes for something else, or a minor injury. I enlighten the parents how to prevent injuries, because children keep getting into trouble. And there are simple things, and if you don't take care of it, you will regret, because this child will get into some kind of an injury. So how to protect and child-proof your house, because children, they run behind each other and one child
Right.
bangs the door and the other child is just holding on
Oh
to the
yes,
edge.
very
And then
commonly.
the finger gets cut, and I get such cases. They bring the cut piece, sometimes they forget to bring the cut piece. We do the repair, we do the reconstruction, and we can restore the hand.
Wow.
So this is one aspect. The other aspect is certain special conditions and situations that are mainly seen in children, for example, birth defects, congenital anomalies. Certain congenital anomalies, people immediately know that they must see a plastic surgeon, for example, cleft lip and cleft palate. Everybody knows.
Right.
Although it is an area where maxillofacial surgeons, sometimes in some places ENT surgeons, but by the vast majority of such cases are dealt with by plastic surgeons.
Just to make it little clear for our audience,
So cleft lip is when a child is born with a split in the lip. And there's also associated nasal deformity. And cleft palate is when the inner part, the palate, the roof of the mouth, there is a gap. And such cases need to be corrected. Now, the important message that I want to give is for each of these birth defects, there is an appropriate age. For example, a cleft of the lip, usually best repaired by third month of life. Okay? And
but why not early, Dr. Mohan? Because I think breastfeeding becomes difficult in cleft lip, right?
Early it can be in a very dedicated center where neonatal anesthesia in the first week or first month of life is very well established. Yes, there are centers where they do it soon after birth, but the majority do it at third month because the risk of anesthesia is less and it's a little bit easier to handle a slightly older baby. The airway is better and so many things are better. So, and there's nothing lost by waiting for the first 3 months.
Okay, but then what about breastfeeding?
No, there is no problem with breastfeeding in a cleft lip baby. The problem is more in cleft palate babies. So there we have to advise on special nipples, expressed milk put into a bottle with a special long nipple with an extra hole, extra large hole, these sort of things, or feed by spoon. There are, ways that we counsel the parent how to feed a baby who has got a cleft palate.
So third month.
Yes. So, for example, there may be children born with fingers conjoined together. So we like to operate these, let's say, around second year of life.
I'm sorry, to be very specific for our audience, we are really covering month by month when the intervention is really required. So please see your doctor. Don't delay the surgical procedures. It's very important.
Yes. So, even at 1 year of age, nowadays, we can operate and separate the fingers. Now, I must emphasize here that this operation, first time, it should be done very well and successfully. Otherwise, the fingers can get deformed. And that in future may be very, very difficult, if not impossible to correct. So again, what it brings us to the fact that pediatric plastic surgery is a highly specialized field because we are dealing with very delicate tissues. We are dealing with a growing child, the impact of growth in future. And sometimes, some conditions, if you delay, then secondary deformities develop, which are more difficult to correct. Let us say a child born with prominent ears like that. Okay, these children get teased in school. So we like to operate them in the preschool age, 4 years, 5 years of age. So for each anomaly, there is an appropriate age when we should do this procedure. Like 6 months ago, I got to see a woman who's 19 years of age. And she came with huge black nevus on her body, congenital giant nevus. It's a rare condition.
How old?
She was 19. Okay. So I asked her, why are you coming now? Why didn't your parents bring you earlier? She said, when my parents took me to a doctor, the doctor said, wait until 18 years of age.
Oh.
And that was such a bad advice.
Seriously.
Such a bad advice. Because these giant nevi, we need to start operating from the first year of life. And by the time the child is 6 years old, we would have finished the job.
True.
Now we cannot take advantage of the growth. Right?
True.
So that is one case.
So what are the benefits of intervention, early intervention in terms of giant nevus?
What I'm trying to say is that in some conditions, for example, if they bring a child with a bad scar, as long as the scar is not too disfiguring and it's not causing a functional problem, I will tell the parents, wait until the child is a teenage. Why? Because between 2 to 14 years of age is a bad scar forming age. So even if I do a scar revision at that age, the scar may not turn out to be optimum. General public believes that children, they don't form scars. The truth is just the opposite. Children heal fast, but they form aggressive scars. So if you can delay it, we prefer to delay scar management, or rather scar corrections, scar revisions, until about middle of the teenage. So as you see here, for every condition, there is an appropriate age. That depends on the child, on the location of the scar or the problem, and on the parents, on so many factors.
Right.
So suffice it to say that if there is a structural problem in a child, consult a plastic surgeon. He may not operate or he may not suggest to do now, but at least get the correct advice. And this is where I want to put out the message to pediatricians, because pediatrician would be the first point of contact for parents. And the pediatrician might have the wrong idea, as it happened in this 19-year-old girl, that the pediatrician might say, okay, wait until 18. That is a general thing. Okay, let that person become an adult and then we will see. Then let that person decide what to do. You see? For example, in the condition called syndactyly, where the fingers are joined, I just told you that we should operate around 1 year of age or before 2 years of age. Some of these children also have conjoined toes. There I tell them there is no need to operate. Because if two toes are joined together, it makes no difference to the child's ability to walk or run. And operating on small toes in young age may be more problematic and might produce a bad result or a scar with which the child will have to suffer. So I tell them that, okay, wait, let this person grow up and then this person can decide whether to separate the toes or not. Because cooperation with dressings and everything is important. That is very difficult to obtain in a child. But the same advice is not given when the hand is involved. You see how things change.
Great.
So it's only the specialist who can give the correct advice on the age appropriateness.
Right.
Now, the other problem I find when dealing with children, and when I suggest a surgery, immediately the parents are afraid of anesthesia.
Yeah, true.
There is no need to be afraid of anesthesia. A newborn baby can be given anesthesia if necessary. Otherwise, in good hospitals with expert anesthetists, all children of all ages can be given anesthesia. It's not a problem at all.
True.
So
I mean,
they don't have to be afraid.
a fear of anesthesia, you're making a long-term suffering for a child.
That's right.
It's not a wise call to
right.
do. And pediatricians have to be really wise in advising the parents that early intervention is really required.
Yeah, if the pediatrician is not sure, then he or she can refer the patient to a plastic surgeon. So that's the message I want to put out.
True.
Other than that.
But then, Dr. Mohan, the giant nevus. Okay,
Yes.
for the general public, what exactly is giant nevus? How it looks like?
First of all, it is rare. But because I'm dealing in these cases, and somehow on the internet, when people search, they find my name. As an individual doctor working out of a single hospital, I have seen more than 20 cases, and which is a huge number. Considering these cases are very, very rare. Okay, so now all of us understand about moles, right? Small moles. Suppose the mole is big, about let's say 2 centimeter, 3 centimeter. We call it a large mole. But imagine if half the face is covered in black skin. Imagine if the entire upper limb is covered. Imagine the entire chest is covered. Entire back is covered. 30%, 40%, 50% of the body is covered in black, hairy skin, like an animal skin. There is such a condition. And babies who have this condition, the parents are aghast. First comes the shock, like, what is this? And then immediately they ran to the obstetrician. Obstetrician has no clue. She will refer to pediatrician. Pediatrician, if the person knows that yes, a plastic surgeon can deal with it and must see early, may give the wrong advice.
True.
They often go to a dermatologist. The dermatologist may not ever have seen this condition in his or her life because it is rare. Even many plastic surgeons have never seen such a case. But plastic surgery works from basic principles. So even if I have never seen a congenital giant nevus, and if this is the first case I'm seeing, as a plastic surgeon, instinctively I know what is to be done. And of course, I will look up the literature and decide what I am thinking as the plan. Is that the correct plan? Is this what the world does? And that's how my journey with the congenital giant nevus started. In Dubai, I'm finding a lot of these, not from Dubai residents, but we are now draining such cases from the entire region. I'm getting patients from Iraq, from Egypt, from Saudi.
Beautiful.
And the entire region, we are getting this. So these children need to be treated early. So this is a glaring example of how wrong advice can really mess up the plan.
True. Yeah. How early intervention gives benefit to this procedure?
Because in early intervention, we can take out part of the black skin and advance the normal skin. Okay. Now suppose I'm able to take out a 3 centimeter strip. That 3 centimeter in a baby represents a bigger proportion than 3 to 4 centimeter in an adult. And baby skin is soft. So I can easily take out a 3 centimeter strip and directly close. So that much of nevus I have eliminated. If this child grows into an adult and I take out 3 centimeter and close, like it's a drop in the ocean. I've done nothing.
Right.
I've done nothing.
Right.
And then the child is growing. So once I pull the normal skin, this normal skin is under slight tension, it grows. 6 months later, I can pull it again. So by the time this child is 3 years old, I would have done 4 or 5 surgeries, and I would have taken away a significant part of the black skin and replaced it with normal, completely normal white skin by pulling across. After 3 years of age, we start placing balloons, tissue expanders under the normal skin, and inject saline water every week. The balloon grows. So then there is more of the normal skin that is produced by the body. Just like when a woman gets pregnant, in 9 months, her tummy becomes this big. Where did all this skin come from? It was produced over a period of 9 months. Same way, over a period of 3 months, this tissue expander grows because we are injecting saline into it, and then more skin is generated. 3 to 4 months later, we remove the balloon. Now we have lots of skin.
Yeah, loose
we
skin.
advance that skin, and that much of black skin is removed. Again, you place balloons. So this we start from 3 years of age, because before 3 years, it becomes difficult to manage the balloon for injection. Everything becomes an uphill task. So my protocol is 2.5 to 3 years of age, I do serial removal, and after that, I will use balloons. We have many successful cases where
Right.
very large nevi
We
been
have,
removed.
for our audience, we have created a separate playlist on Expert Medical Insights of Dr. Mohan, where it's a section of giant nevus. You can go through the videos and see how the procedure is done. You can see the before, after as well, and the results, so that it's helpful information for the audience as well.
Right.
Cool. So that's giant nevus. Any other common procedures or surgeries in pediatrics which...
Well, it depends on the individual networking that the plastic surgeon has with the pediatricians. I mean, I get referred all kinds of cases, too numerous to mention here, but anything where there is a structural problem in a child or as a result of injury or burns, one important condition is a hemangioma.
Yes.
Like children are born with a reddish birthmark. Okay. Now there is a lot of ignorance even among medical circles about this condition called hemangioma. Everything gets called as a hemangioma. So there is hemangioma, there is vascular malformation. The two are different. Hemangioma will disappear by 7 to 9 years of age. A vascular malformation will never disappear.
Okay.
So a hemangioma, a true hemangioma, because we are very familiar with these conditions, so we can, from the history and from examination, we can make out this is a hemangioma or this is a vascular.
But they both are red color.
They are both red
Okay.
color. Okay. So if it is a hemangioma, nowadays you will be surprised to know that neither surgery nor injection of steroid nor any of those earlier treatments are needed. Number one, it is going to disappear. So if it is small, it's not in a critical area, you don't have to do anything, it's going to disappear by 7 years of age by itself. Or nowadays for big ones, we are giving medicine called propranolol, which is a beta blocker, as you know.
Okay, propranolol.
Very strange, very strange. So here we collaborate with the pediatrician. This is a reverse collaboration, because this child might be referred to me by a dermatologist or by somebody, or they may come directly to a plastic surgeon. Then I will call up the pediatrician and I'll say this child requires propranolol treatment. And then the treatment of this medicine is under care of the pediatrician.
It's an advanced research?
It's been there for more than 15 years now.
Really?
And it works. It was an incidental discovery, but it works and is now the standard of care.
That's nice.
So that's just an interesting aside. So vascular malformations, we do manage. And hemangiomas, we do manage. Okay, that's another area of active collaboration. Pediatric surgery is another area of collaboration where this is, a pediatric surgeon is a surgeon. Often he's a general surgeon dealing in pediatric age group. So all his or her patients will be pediatric age, but he's a surgeon or she is a surgeon. Now, pediatric surgeons, depending on their training, can also perform some of the plastic surgical operations, like a cleft lip and palate, hypospadias. Hypospadias is a condition where the urinary opening is abnormally located in a male child. All right. So these sort of things, a pediatric surgeon can deal with it. But if that pediatric surgeon is not trained in the plastic surgical aspects, it depends on the training background, then that pediatric surgeon might refer such cases to a plastic surgeon. And both of us being surgeons, we can work together and we can collaborate to the best interest of the patient. So very often, I might invite a pediatric surgeon to be part of the team so that we can offer the best to the patient. So both being surgeons, we understand each other, and we can work together in unison perfectly well.
So, what message you would like to, give to our parents in terms of pediatric surgery cases when they are when they are scared or
Don't
to
be
approach?
scared. Don't be scared to see a plastic surgeon. He's not going to jump on your child and operate. We are not surgery crazy, but we have the right training, the knowledge to guide this child. What is required, when that is to be done, is surgery required or not required? For example, in the hemangioma, I said surgery is not required. They might come to the surgeon thinking that I will remove it, but I'm going to tell them this is to be treated medically. So just for the correct advice, and you can see 1 time, 2 times, 3 times until you make up your mind, do your own research. But you please understand that plastic surgeon is the appropriate person to consult for such conditions.
Absolutely. Unless and until you are satisfied, you go ahead having 2 or 3
And not
consultations.
to be afraid of doing a surgery under anesthesia if it is necessary.
True.
Yeah.
True. Wonderful. So that's P for pediatric surgery. And now coming to P for physiotherapy.
Of course.
I think there is a very big collaboration between physiotherapist
Absolutely.
and plastic surgery,
especially
right? Can we
especially
highlight
in
that?
hand surgery, because many plastic surgeons like myself are also hand surgeons, and most of the hand surgery requires post-operative physiotherapy. Some of them require pre-operative physiotherapy, and some of them require splint therapy, specialized splints to be made to position the hand in a particular way or to encourage movements of the hand. So to get the best result out of the surgery, let us say it's a tendon repair, let's say it's a contracture release, physiotherapy becomes an essential component. Now again, active collaboration between the physiotherapist. Generally, we like to have dedicated hand therapists with whom we would like to work. If a center doesn't have a hand therapist, the general physiotherapist can also perform under guidance from the plastic surgeon. So as plastic surgeons, we also learn about physiotherapy aspects, the splint aspects, so that we are able to at least guide and oversee the comprehensive care of the hand injury patients. So this is an important area. Other than hand injury, many of the other reconstructive plastic surgeries require some sort of a splint, some sort of compression garment. For example, if I operate on a scar, a compression garment is absolutely essential. Post-burn treatment, compression garments are to be worn for 6 months. And I see many cases where burns are treated and then the patient is left without a garment.
Oh.
And 6 months later, they come to me with horrible keloids and hypertrophic scar. My first question to them is, where is your compression garment? They look at me like that, no, we were not advised any. And I'm so surprised that this person has gone to a hospital and had the treatment done successfully, but nobody told them to get the compression garment. So you see, therefore, there are many, many conditions that we deal with where surgery is one part. The follow-up care with physiotherapy, specific massages, wearing of a compression garment, use of splints, all this is going to make the difference between success and failure. So physiotherapy also, there are conditions where the physiotherapist is struggling to get the result and the result is just not happening. If they send this patient to a plastic surgeon, we recognize that there is a contracture in the skin, there is a skin shortage. If there is a skin shortage, we have to release that and provide a skin graft.
So what is contracture for our
Contracture is, for example, this unable to stretch. There is a scar, or there is a scar, the fingers are unable to stretch. Now, that is called a contracture. Now, contracture can be due to skin shortage, or it can be due to joint structures which are tight. If the joint structures are tight, yes, stretching, physiotherapy is going to work.
So these are all post-surgery?
No, can be post-burns, can be post-trauma. Classical example, a child, children are always, getting into trouble.
Right.
So let's say a mother has a couple of children, she gains weight, she thinks she must get back to fitness. They buy a treadmill. There is a treadmill at home, and the mother is working on the treadmill. It's fascinating for the baby, for the child, toddler especially. The toddler will crawl and get over the treadmill, a running treadmill. Or a younger child will try to emulate the mother. And they fall, and the treadmill is running, and the finger gets friction burns. Now, very often such children are sent to physiotherapy. Physiotherapy is struggling, child is crying, mother is crying. Nobody realizes that this is not going to go anywhere. It's not going to work because there is a shortage of skin, because the skin got burnt off by friction. So the physiotherapist needs to send this child to a plastic surgeon, at least for a consultation, to say just physiotherapy alone, or is there something that you have to do? And when I see that there is a shortage of skin and the skin itself is pulling, I have to release it. I have to do a skin graft. Again, parents get scared. Oh, my small child, how will it tolerate anesthesia? So what happens here? The surgery, which is essential for the child, is not done. Physiotherapy is traumatic because it's not going to go anywhere. The child is traumatized because of the pain and fear. Ultimately, the child has a contracture. Now, this contracted finger will contract or pull on the bone. The bone will get bent. This person, when they come at an older age, impossible to correct. The bone has got bent because of the pull.
Right.
You see?
And it's painful.
Painful, that hand is crippled. And in the first couple of weeks, if they have come to a plastic surgeon, the plastic surgeon would release this, take away the burnt skin, do a skin graft, beautiful results.
How much time usually takes in terms of like hand contracture? I have some.
See, for example, especially this treadmill friction burns is a very tricky thing. It all looks normal here, but that skin has got burnt deeply because of the heat and the movement. So only an experienced plastic surgeon can recognize that this skin actually is dead. Now what happens is slowly that skin will fall off, slowly contracture develops. So at no point in time they will have a big wound, but the finger goes bent like this. So an experienced plastic surgeon can foresee what's going to happen, can advise the parents, look here, this skin needs to come off and I need to put a skin graft now. And then followed with splint therapy and physiotherapy so that your child can have a full normal function. If they refuse that advice, unfortunately, they think that the surgeon is hungry for money or something. I'm telling you the truth, what people think. They go away and come back. And I've had many cases come back to me a year later. Doctor, what has happened? I said, I told you so. Okay, now can you do something about it? If they come within 6 months, 1 year, I can still do something about it. But if they come very late, then the damage is done. So what I'm trying to say is there are situations where collaboration, a cross consultation is very, very helpful for the overall planning and for the prognosis of the patient in question. There's no harm when it involves skin and structures and you see things like contracture. A physiotherapist, experienced one, will know if he or she has worked with a plastic surgeon. See, many hospitals don't have a plastic surgery department. In many places, the physiotherapist mostly works with orthopedic.
True.
So they don't realize that plastic surgeon has an insight and an input to give, especially in such cases like hand.
That's a good information because people usually feel like it's okay, time will pass, but later on it becomes a difficulty.
Right.
So that's about the context. So that's
there
how
are-
physiotherapy.
There are other conditions where the muscles are in spasm. For example, cerebral palsy. Cerebral palsy children are undergoing physiotherapy on a regular basis. But if there is muscle imbalance and the physiotherapist recognizes that, the physiotherapist can consult a plastic surgeon and I can do Botox on the spastic muscle to balance out the muscle that causes the bend and the muscle that causes the opening of the elbow. These are called agonist, antagonist. If the agonist and antagonist are in imbalance, the physiotherapist is just struggling without getting results. So the overpowerful muscle needs to be weakened a little bit, but few shots of Botox can do that. So you see how our knowledge of Botox, which we are using for cosmetic purposes.
True. It's surprising. People must not be even imagining Botox can be used for such kind of cases.
And I do get a few cerebral palsy children who come to me regularly because the physiotherapist who's managing them knows about this. So they refer.
That's very important message for the physiotherapist also to know that, we do these procedures. So that's another area in physiotherapy where the collaboration exists.
Alphabet P.
That is alphabet P. Coming to PQQ, there is nothing. Then we come to R. R is rheumatology.
R is rheumatology, R is radiotherapy, R is regenerative medicine.
So many, yes. So which one you would like to choose to go ahead with?
Let's go to radiotherapy because that's quick.
Yeah, okay, good.
We know that radiotherapy is used for cancer treatment. Can be any part of the body. It's an important part of cancer control, cancer treatment. Okay, it's made a huge difference in the prognosis outcome of many cancers, especially, for example, breast cancer. But the downside of radiotherapy is that the whole area becomes tight. The skin undergoes some peculiar changes and tightness, and that person might suffer from shoulder stiffness, might not tolerate even the touch of the clothes on the skin. Okay, so it produces color changes in the skin. The breast becomes tight and shrunken. If there is an implant, there will be capsule contracture. So, and sometimes after many years, the radiotherapy area may develop a skin breakdown or an ulceration, and these ulcers never seem to heal. So this is the downside of radiotherapy. Now, in the past, there was no good treatment for this. But since regenerative power of fat is now known for the last 25 years, fat grafting has come to play a big role in reversing some of the changes of radiation-induced damage.
Wow.
So we take fat from the non-radiated area of the same person, process it briefly, and inject it into the radiated area, and that seems to soften the skin, reverse many of the radiation damages. Even radiation-induced ulcers and wounds can heal. So for the first time in medical history, we have something which can reverse or correct some of the bad effects of radiotherapy.
Wow.
This fact is not widely known among doctors, even among radiotherapists. It's not known.
Yeah, I'm sure, because many they don't know really. It's amazing.
So there's a message out there that if you are suffering from any radiation-induced damages, quality of life issues, consult a plastic surgeon. We may be able to help. Okay.
Fat grafting is amazing.
So that's the message regarding the field of radiotherapy.
But how soon can they see the results? Is it any harmful? Because definitely cancer patients are any which way, immunity compromised, so they are scared that further interventions and all that.
Well, that is true. So many of these radiation-induced damages happen over several months. So let's say 1 year has passed and most of the anxieties related to the cancer cure are kind of over. Now the person is in remission, everything is okay. Now comes the quality of life issues. Okay, sensitivity of that area, tightness of that area, deformity between two breasts. So many of these issues are there. Tightness in the chest, difficulty in breathing. Yeah, all kinds of problems.
People kind of compromise with all this.
They live with it. They live with it, and they are told, okay, this is radiation damage. Nothing can be done. You live with it. That's not true. Something can be done about it. Fat grafting helps.
Creating awareness is very important for this one.
So that's
radiotherapy.
Then rheumatology, of course, we don't have too much to do in rheumatology, but again, the advances in regenerative medicine have opened new doors and new windows where certain rheumatological conditions can be improved by fat grafting. You see, fat graft has phenomenal, beautiful properties. It is anti-fibrotic, anti-inflammatory.
Anti-fibrotic as well.
Improves blood supply to the area, improves healing potentials. So the stem cells from the fat contains stem cells. So I can give you a real example. 2 years back, a lady came with a wound. She's got a rheumatological condition. She's on high dose of many medications. And she got a wound in her finger and it went into the joint. The joint got opened. This is called a septic arthritis.
Okay.
And as a doctor, septic arthritis is bad prognosis. Yes. So this patient was referred to me by the rheumatologist because he happens to sit in the next room. Okay. So he said, Dr.
I'm glad
Mohan,
everyone is around you in the nearby rooms.
He said, Dr. Mohan, what can you do about it? So I looked at it and I didn't want to do any surgery because the surgery might fail.
This is surprising. Septic arthritis, fat grafting.
Yeah.
Wow.
So we put her on antibiotics, etc. And then we just took her fat, took her blood and prepared a platelet gel. And we injected it all around there. And she was just told to do dressings with betadine and then, take some antibiotics for some time. And I was amazed to see that it healed.
Wow.
Just by injection of fat grafting and, stem cells. Similarly, there are people whose face is so tight in a condition called scleroderma, which is again a rheumatological condition.
Right.
We inject fat graft, the cheeks become soft, the color improves.
With fat grafting?
With fat grafting.
Wonderful.
Rheumatoid arthritis, as you know very well, can affect the hand in a major way.
Yeah.
Joints can be destroyed. So there are procedures that hand plastic surgeons can do, synovectomies, and alignment of the tendons and even joint replacements. Right. So just like you have knee joint replacement, you can replace this joint, you can replace this joint. There are tiny artificial joints available. We can do joint replacement and realign the fingers and make the hand more functional again. So rheumatoid arthritis, women, because usually it affects women more than men, suffering from hand deformities.
It's too painful. I know.
But so they need multidisciplinary. Of course, they are under care of the rheumatologist. But not to forget that deformed hand, you don't have to live with it. The hand deformity can be corrected by proper hand therapy and splints, and if necessary, where necessary, surgery.
So, say for example, one finger has is got affected by RA. How early a person can get rid of that particular suffering when he or she goes for the surgery?
So medical treatment is the foundation.
Right.
So under care of the rheumatologist. So many of these things can be, at least disease can be modified, disease can be halted by use of medications. But if there is a deformity that has already developed, let's say a tendon has ruptured, let's say ligament laxity, these things can be corrected by surgeon.
And how early they can get back to their normal, because it's a surgery, people are still scared.
We don't want to operate when the disease is very active. So we consult with the rheumatologist, the disease is in remission, and then we can operate. Yeah, of course, the timing has to be chosen properly.
So after that, how much time it takes for recovery?
After that, there is a splint therapy. Okay.
So a month to two?
So a month, 2 months, yeah, sure.
Back to normal, huh?
Back to
That's wonderful.
Better function.
Wonderful.
Yes.
But this is strange. Septic arthritis, it's beautiful.
Yeah, so really the regenerative powers of fat are amazing at times.
I think we should have another podcast just on fat grafting.
Sure.
It's beautiful.
So that brings us to R for regenerative.
Yes.
So on a broader front, because plastic surgeons are doing fat grafting, and now we, more than any other specialty, know that fat is so rich in stem cells, and we are using this in the separated purified form or the crude form together with the fat. We're using it for improving the contour, improving the beauty, rejuvenating the face, hands, various areas, right? So because of that in-depth knowledge, we're able to offer regenerative solutions for several problems in other specialties.
That's amazing.
Plastic surgeons are nowadays more and more getting into regenerative medicine, and that brings us in close contact with other specialists who are also exploring the power of regenerative medicine. There are regenerative societies where there will be orthopedician, there will be plastic surgeon, there will be immunologists, and all the people who are interested in regenerative, neurologist even.
Wow.
Because again, regenerative has value in neurodegenerative conditions. So that's a separate evolving field.
It's very nice. Yeah. It's great.
So
that comes to R for rheumatology. We finished R. We have anything left there?
I think
okay.
so.
So, okay, great. So next is S for surgery.
So S is for surgery. Of course, plastic surgeons are surgeons. And so general surgeons, we do interact with them. Now, one field of close cooperation is the field of bariatric surgery.
We covered that in B.
Already.
Yes. But still a glimpse of it.
So that's because surgeons are doing this kind of work, and the patients are losing tons of weight. So they have all these loose skin and tissues, and which need correction. The plastic surgeon can do it very well. Or if the general surgeon wants to get involved together as a collaborative effort, we can do. Now, one area where I have interacted with general surgeons is in complex hernias, difficult hernias, recurrent hernias. So in these cases, we can work together because we are experienced at moving the tissues, muscle slide procedures. There are many procedures where we are able to use the abdominal muscles in the best possible way to restore the muscular anatomy to as normal as possible.
To prevent the recurrency?
To prevent the recurrence and also to close those hernias which seem to be initially impossible to close.
Okay.
Big hernias, okay? And together with tummy tuck sometimes, because such patients often also have a big apron. That apron is dragging down on the hernia. So a combo procedure is planned. Other area is, of course, oncology, because general surgeons do get involved in various cancer surgeries. So collaboration with the general surgeon is very often done. Sometimes there are situations where the patient is concerned about the scar. So the general surgeon will ask me, like, how shall I place the scar, or would you like to come and do the closure because the patient wants to have the best scar outcome. Or the general surgeon might have done a surgery, let's say in the neck, let's say thyroid, let's say lymph node dissection or something, and the scar outcome is not good, so they may refer to the plastic surgeon for that. So there are innumerable areas where there are collaborations between general surgeons and plastic surgeons. And
any common procedures coming in your mind? Thyroidectomy is there.
Well, thyroidectomy is done by the general surgeon. I don't do the
No, I'm not saying about that. The scar revision and any other surgeries.
hernias, for example, sarcomas, for example. These are cancers commonly in the limbs. Sometimes there is a sarcoma type of condition which has been operated, let's say, and it has recurred. Now, recurrent sarcoma is a major resection is required, which will leave a big defect. And someone has to plan to correct that defect. Right. So the general surgeon, together with the plastic surgeon, can do the best optimum care for that. So it is not good if the general surgeon will just take out the sarcoma and just leave it like that, or put a skin graft. Careful planning, we can do a very good restorative work. Respecting the oncology part, respecting the cancer part of it also, that it is completely treated, while at the same time also correcting the problematic area, refilling the area, restoring the normal anatomy. Sometimes I have to shift a tendon from one area to the other because in the sarcoma that one muscle has been removed. Right. So there's going to be like a foot drop or something. So we can do a tendon transfer at the same time.
Wow.
So, I mean, examples are innumerable.
Right. In orthopedic
Trauma,
also, I think there is,
for
yes.
example.
We will come to tea.
We come to tea already.
Are we at tea already? No.
Well, from after SST.
We finished surgery. Now it's the tea, trauma. So Dr. Mohan, there are many patients who are bedridden at home and they have bed sores and all that. So how a plastic surgeon along with wound care, how it goes hand in hand, they should approach a plastic surgeon for that.
This is a morbidity that is there in society. First of all, of course, it's important to prevent them by moving
again
proper
regularly.
bed and proper pressure relieving type of mattresses and all that. That's a full topic to be covered some other time. Now, home visits by a wound care nurse will be very useful. But a plastic surgeon can give an advisory role. Sometimes I advise, they send me the photographs, and then I advise what kind of dressing is to be done, if surgery is required or not required. If the person is medically able to tolerate surgery, which can sometimes be done under local anesthetic, I can do a local flap and fill that pressure sore area. Okay. I can also act as a resource person for the wound care nurse. She can consult me and offer the appropriate dressing care and treatment regime to the patient who is having a pressure sore. And in hospital, plastic surgeons perform an important function of educating the nursing staff about pressure sore prevention and also going and seeing and consulting, like for example ICU patients who might have a pressure sore. They often send me the referral, I go see them and we plan the treatments.
Right. Yeah. So it's a very important, it's very common in bedridden patients.
Pressure sores are preventable but not always. We recognize that.
Right.
And we must offer maximum support to the family that is looking after such patients.
True. So there we finish our S. Coming to T, trauma.
T is trauma. And the birth of plastic surgery, the modern plastic surgery is born out of World War.
The war, you told me, yes.
World War I and II. So plastic surgeons have a lot to contribute to trauma, and very often they can be the second line of call in complex trauma.
The fire rescue, the rescue service.
Rescue service, yes. So no, but in multi-system trauma, of course, the ABC and all those life-threatening injuries, those take precedence. But such polytrauma patients also have many wounds on their body which require plastic surgeons' inputs. So we do collaborate with orthopedic, with neurosurgeon, with general surgeon, and maybe not on the same day, maybe the next day, okay? We are involved. So plastic surgeons are very much involved in trauma management as a part of the multidisciplinary team, and that offers the best care to the patient, especially with multiple injuries, polytrauma. So we are part of the trauma team.
Dr. Mohan, how early intervention in terms of trauma cases is crucial when it comes to plastic surgery?
Like I said before, life-threatening injuries take precedence, like intestinal injuries, blood loss, brain injuries, etc. But once these are sorted, at the minimum, the wounds should be debrided. Debrided means cleaned to remove all the dirt and roadside contaminations, take away dead tissues, and manage the wound in such a way and provide a sterile dressing. That should be done in the beginning, because if that is not done, this large wound is going to have a roaring infection, then it may be very difficult to salvage. That may even result in the death of the person due to sepsis. So wound cleaning, once it is done, as sterile dressing is applied, then there is no urgency. In fact, sometimes reconstructive procedures are delayed on purpose for the swelling to settle down. And third, fourth, fifth day, when the patient's condition is more stable, we can do that.
Are there any cases, Dr. Mohan, you have come across where early intervention of plastic surgeon has, you have actually got rid of disability?
There are plenty of such cases. There are some industrial accidents that happen in, for example, in the industrial area, Jebel Ali and all that. So we used to occasionally we get massive injuries. Many of them go to the government setup, but sometimes they come to the private setup also. I do remember one guy was loading, unloading, and a forklift came from the corner, didn't see him, and the forklift virtually impaled him at the thigh level and ripped off.
Oh my goodness.
Yeah, so he had an extensive injury of the upper thigh, genital area, and so on, so on. So these were brought to our hospital where I was working earlier. And this, I got involved primarily because it's a huge soft tissue avulsion injury. And such injuries, we understand them very well. So I got involved right from the beginning, did the debridement, applied this negative pressure wound therapy, managed the wound, reconstructed him, and he walks with no disability. So there are such cases where early intervention, forward thinking, forward planning makes all the difference.
So that's T.
Yes.
Traumatic. Okay. Next is you, coming to urology.
Yes.
Yes. So how the plastic surgery and urology go hand in hand?
Well, urologists sometimes deal with structural problems or congenital problems. Like I said, hypospadias. So hypospadias may be repaired by the urologist or by the pediatric surgeon or by the plastic surgeon. Sometimes there are cases where the hypospadias repair has failed, and so redo cases sometimes are referred to the plastic surgeon because it might need some flaps, some more delicate work, tissue movements.
Right.
So that is one area. There are other areas where the genital structure is not okay. So like intersex cases. So once the sex of the person is determined properly that this is a male and to be reared as a male, then reconstructive surgery is required to make the genitalia appropriate for a male.
Right, very important. True.
If this is called ambiguous genitalia. Looking at the genital in a newborn baby, you don't know that this is a boy or a girl.
Right.
Intersex, that's called intersex. So there is a protocol to be followed. Once all that protocol is followed and we say, okay, this is a girl, then we have to do reconstructive work on the genital area to make that more correctly feminine. So this is an area where urologists and plastic surgeons can collaborate. There was one such case which I operated around 20 years ago, and that girl is now, of course, 20 years old, and she came and saw me 2 months back to do further work.
Nice.
And I was so happy to see this person. I remembered this child, which we had operated at the age of 6 or something. So, so that was collaboration with the urologist.
That's nice.
There are areas, for example, there are rare infections which come in that area which destroy part of the tissue.
Like
Fournier's gangrene. So classically these will be seen by the urologist, but later referred to the plastic surgeon for skin grafting and that sort of management. So there are few areas where we work. Of course, another area which is not the usual norm for plastic surgeon, but my career happened to be that way, that I was also part of kidney transplant team. So their urologist works together with many other specialists. And I happen to be part of that, although I am from the plastic background. But of course, the first
Joseph Murray
was done by a plastic surgeon.
I can never forget that. Yes.
Which is a surprising fact.
Yeah, true. Then there is this viral warts cases.
Yes. You're right.
Radio frequency, CO2 ablation and all that.
That's right.
So
because we deal with carbon dioxide laser for various other indications, so sometimes such cases are referred to us by gynecologists or by urologists for getting rid of these viral warts by use of laser.
Okay, so the normal laser technicians and they cannot do that?
No, this is not for... No, the laser technicians are only allowed to do like hair removal and that.
Dermatologist?
Dermatologists can do.
Can do. Okay. Of course. So there's a condition called cryptophallis also where plastic surgery plays a role,
Well, yes, there
right?
are so many such unusual conditions. Cryptophallis means that the penis is not visible, it's hidden. And this happens most commonly if excessive circumcision has been done. Let's imagine a circumcision done in a baby and too much of the foreskin is removed. At that age, the surgeon doesn't realize that he or she has removed too much skin. When this person grows older, the penile skin is all gone.
Yeah.
So the penis goes inside.
Right.
And so obviously this is a major functional problem for now that the person is an adult. And you look there and you see the penis is not there, it's hiding inside. That's called a cryptophallus.
Right. How early people come to know about this condition?
Well, maybe in late childhood, teenage, it'll become obvious.
So early intervention
The
is
person
better.
may be embarrassed or may think that this is normal until he or she is old enough to realize that I am different from the other boys. So, well, the correction can be done very easily. I mean, we have to release everything, restore the length and do skin grafting.
It's, I mean, many parents are
It's
there, like
successful.
they're scared of doing this procedure as well.
Well, if the child has a short penis and they see the doctor and they will see a plastic surgeon and the plastic surgeon can determine that actually it's not a short penis, it's buried penis. Because the skin, excess skin has been removed at the time of circumcision.
Right.
This can be done. The other situation where this happens is when the person is over obese and the abdominal apron is just hanging in front and pulling the penis inwards. Those cases also we correct them. Yeah. So sometimes such cases may land up with the urologist, and then I will get the referral and I can correct that. Yes.
There is something called male body contouring and gynecomastia also, which is related to urology, Dr. Mohan?
Sometimes such patients may land up with a urologist. The urologist can refer them to us. So for male health.
Right.
Yeah.
And vasectomy or vasectomy kind of procedures
Those
also?
are done, vasectomies are done by urologists, but if the vasectomy reversal is required, we being microsurgeons, the best results are when the vasectomy is reversed by using microsurgical technique. Of course, a microsurgeon can do that. And this rarely we get such referrals, yes.
Okay. So that's urology. Coming to vascular surgery.
Well, vascular surgeons and plastic surgeons have overlap zone, especially when it comes to lower limb ulcers. So these may go to a vascular surgeon, and if the vascularity is okay, for the healing part, the vascular surgeon may refer such cases to plastic surgeon. So this is an area of overlap. We being microsurgeons, we can also do vessel reconstructions, vascular bypass. These sort of procedures can be done. And again, regenerative medicine nowadays, in cases where the vessel cannot be reconstructed, injecting the fat and stem cells can have a positive impact on the wound healing. And there are also people who are experimenting with injecting stem cells into the vessel for peripheral revascularization, because as I said, the stem cells improve the angiogenesis, production of new vessels. So these are all frontier areas where plastic surgeons, regenerative medicine is impacting on vascular surgery and on wound healing in leg ulcers. So mainly in leg ulcers, we collaborate with vascular surgeons.
Leg ulcers, huh?
Yeah.
Where commonly people come across
Due to
which-
diabetes, due to varicose veins, due to arterial insufficiency and that sort of thing.
Okay, great. So that's vascular. And the
And
last
after
is
the last is
VW.
W is wound care. And as we have touched upon in many
areas we have covered wound care, yes.
that plastic surgeons are the resource personnel and the experts in wound care. And we work together with the wound care nurse in offering the best possible care to people who are having a non-healing wound. Any wound that doesn't heal in 2 to 3 weeks must be seen by a plastic surgeon, because our interventions can speed up the wound healing. We can understand. As I often keep on telling even my patients in a joking way, I say the wound speaks to me.
Oh, that's nice.
I understand the language of the wound.
I agree with you.
I understand the language of the wound. Because we look at the wound, we immediately, in most cases, know what is the problem, what needs to be done, where the wound has stuck, that it's not healing.
It's very important.
So wound care is an important area where plastic surgeons contribute a lot to reduce the suffering and improve the quality of life.
Absolutely. Quality of life is important. So that's where we finished W. XYZ, we don't have anything in XYZ, but we have a lot more to discuss in plastic surgery. So please stay tuned and don't forget to like, subscribe and follow our channel, as well as please share more and more to create awareness among the society, because knowledge is important.
Knowledge is power.
Yes,
now
exactly.
here I would like to actually record my acknowledgement of the trust that other doctors have placed on me to solve these difficult problems that they encounter in their respective specialties. And many of these cases need me to exercise my brain, need me to do research, read up, and that has enhanced my knowledge and experience. And I'm forever learning by managing these kind of cases. Our learning also enhances, and we're able to offer to the next patient that comes based on this experience.
Very true.
So it's very, very important. It's a two-way road.
Two-way road.
And I gain a lot as much as I'm able to give to the patient. I also gain the experience and the knowledge.
Very true. That's amazing. Dear doctors, please do get in touch with Dr. Mohan in case of any discussion, any suggestion, any advice you need in terms of plastic surgery. All his social media link will be there in description as well as in his channel details. So get in touch with him. Thank you once again. Thank you, Dr. Mohan.
Thank you.
See you soon again for
a wonderful podcast as usual, as always.
Yes, thank you.
Perceptive questions and insightful discussion.
My pleasure.
Thank
We'll
you.
see you soon for the next session. Yeah. Thank you.
Dr. Mohan Rangaswamy, turning your dreams into reality with precision and care.